Well, thank you for braving the snow. This is an amazing audience. I think it's beautiful out, but I know that it's early and it's quite challenging out there, so thank you for being here. Jackie, thank you for the very kind introduction. I'm very grateful to ARVO and the ARVO Awards Committee for this honor and the opportunity to speak to you today. I'd like to thank Dr. Emily Chu, who nominated me, and the co-nominators, Dr. Tom Lietman, Director of the Proctor Foundation, Dr. Todd Margolis, recent Chair of Ophthalmology at Washington University, St. Louis, and Russ Van Gelder, Chair of Ophthalmology at University of Washington. Here are my disclosures. I also will speak about medications that are off-label for the treatment of ocular inflammation. So take a look at this photo, and this, and this. Also this, and this. These are all images from eyes of patients who have uveitis, which is a group of conditions characterized by intraocular inflammation. It can affect any part of the eye from front to back, as you can see in these photos. It affects both sexes, all ages, all races, and is responsible for at least 10% of blindness in the United States and more in other countries. Many times it can be recurrent or chronic, and so span years of a person's life, so ongoing treatment is often needed. I quickly realized in practice that the question of how to treat uveitis comes up in every single clinic. The field is making a lot of headway into understanding the pathophysiology of ocular inflammation, thanks to many of you in the audience who do basic science and translational research in this area. But we don't have a cure right now, and we don't have a way to make uveitis disappear. But we can treat, and our treatments are getting better. However, in our field, we often feel like we're practicing trial and error medicine because of the lack of data to guide our care. By doing clinical trials, you can answer questions that really help us to improve outcomes in our patients. The history of having effective medications in uveitis is actually quite short. We really didn't have much to speak of until the 1950s, which is when steroids came about, and that really revolutionized the care and the treatment of autoimmune conditions. However, steroids are not a great long-term treatment for patients with chronic inflammation because of significant and serious side effects. Fortunately, we're now in the era of having steroid-sparing therapies, including conventional agents and biologic drugs. So that brings us to this question. It's a very basic and practical question, but we face this in all patients who need ongoing treatment. And that is, which immunomodulatory therapy should we use first in chronic non-infectious uveitis? So I was very, very interested in answering this question. It's a basic question, but it comes up all the time, and we didn't really have a lot of data. So what did we have? Well, at the time that I started thinking about this question, we actually had no FDA-approved non-steroid therapies for uveitis. Adalimumab did get approved, but that was in 2016, and it's the only non-steroid medication approved. We had very few clinical trials, but antimetabolites, which are conventional disease-modifying anti-rheumatic drugs, that category of medications are often used first line for treating uveitis when you need more than steroids. But the evidence to support their use came from non-comparative retrospective studies. Most of those showed that patients were more likely to achieve control with a drug called mycophenolate mofetil compared to methotrexate. But if you look at the details of those studies, methotrexate doses were relatively low compared to mycophenolate, perhaps due to lack of comfort using higher doses or fear of side effects. We did a survey of our colleagues in American Uveitis Society in 2012, and that also demonstrated a preference to use mycophenolate over methotrexate for the most severe types of uveitis. However, there is a cost differential between these drugs, so there are a lot of ramifications as far as what is prescribed. So The prices have come down over time, but mycophenolate mofetil is still about 5 times as expensive as methotrexate. And because these drugs are not approved for uveitis, they're so-called off-label, patients often have to pay for these drugs. And in other countries, cost can even be a much bigger factor. Patients are often asked to pay for a drug that was thought to be more superior and then incur a lot of financial burden. So during my K23 Career Development Award, I learned how to implement international multi-center clinical trials from my mentor, Dr. Tom Liebman. I worked on corneal ulcer trials like SCUT and MUT, but much of what I learned is applicable to thinking about uveitis trials. One of the things I learned is that you could have a great idea, but you can't just apply to NIH and expect to get funded to do a trial. A trial is a big investment. It can take time and money, and there's a lot of work that goes into it. So you really have to show that the question is of high importance, that there's uncertainty around the topic, and that the trial is feasible. I learned the model from Tom of doing surveys to identify the importance of the question and also identify the uncertainty around the question. And also the utility of doing pilot trials to determine or to show that doing such a trial would be feasible. So I applied all of that when thinking about doing my first uveitis trial that I was leading. We did a pilot trial at Aravind Eye Hospital in South India to show that this would be a great partnership and that they could do an excellent job. And my colleague, Dr. Rathanam, who runs the uveitis clinic there, is truly a stellar uveitis specialist and brought tremendous expertise to the trial. So with that, all of that in hand, the survey, pilot trial, I was able to get NEI funding to do the first-line antimetabolites as steroid-sparing treatment or FAST uveitis trial. The primary question was to compare these 2 drugs, methotrexate and mycophenolate for uveitis. But we also try to extend the impact of the trial by answering secondary questions, like evaluating the utility of switching therapy if a patient has treatment failure or does not have sufficient control on the initial therapy. I want to just take a moment to talk about how the NEI supports this type of research. This falls under the NEI Collaborative Clinical Vision Research Program. The NEI has a very, very long and esteemed history of supporting high-impact clinical trials in ophthalmology. From the early days of supporting the ETDRS, DRS, these diabetic trials, which really positioned ophthalmology as a leader in clinical trials. And that continues to this day. These trials are able to answer questions that have changed patient care. One thing that's very unique about this program is that there is a lot of investment and involvement by the NEI program officials during the trial. There's careful safety and performance oversight and resource monitoring. And I want to say that if you ask anyone who's done trials with this mechanism, they will say that the program officials are incredibly committed and raise the level of research done, help us to overcome obstacles that inevitably are going to come up in every single trial. And I'm extremely grateful to all of them because of what they do. Case in point, so I was excited. I was going to start fast. And I'd worked hard to get to this point, finish my K, and we were all ready to start. And my program official, Don Everett, who was here, and I'm all ready to go. We got the drugs. We actually were on our way to India. And we had applied to do the grant in the United States and in India. But then we got this letter. And this letter is from the HHS, NIH, and it's basically, in summary, saying that because of new liability rules put out by the government of India, we could not enroll in India. So I had a moment of panic. Not a moment, I had lots of moments of feeling like, oh my God, my career is not gonna go anywhere. I can't believe this. Like, I got my first grant, or my first trial grant, and I'm not gonna be able to do it. And that could have been the case. The NEI could have said, no, I'm sorry, this just happened. You can't do it because you need India. You can't enroll just in the US. That was your project plan. But when I think back to that time, I'm reminded of this book called The Splendid and the Vile by Eric Larson. This book describes Winston Churchill's first year as British Prime Minister during the height of the Blitz in London. So a terrible, terrible time, right? There were bombings. Obviously, I have never lived through anything as terrible as this. But for me, it was a bad time. But thanks to Dawn and the NEI, this ended up becoming a time when I was able to grow and find something good in it. And what that was is that I learned how to make new collaborations and expand the network. And so rather than just being in India, working in India and the US, I was able to expand to centers in the US, Mexico, Saudi Arabia, Australia. And also thanks to Dawn and the NEI, we were able to eventually overcome the obstacles in India, and they were able to also join the study. And so that's just a case in point of the program officials being instrumental in this process. So we were able to successfully complete this trial, and we published our results in 2019, and I'll share a bit about what we learned. So this was a randomized trial. Patients did know what they were getting, the methotrexate or the mycophenolate, but all of the outcomes were masked. So the ophthalmologists measuring the uveitis or examining the patients, the visual acuity examiners, all the people doing the imaging, they were all masked. One thing about the medications. So remember I said that when you look at the retrospective studies, the dose of methotrexate in most of those was quite low. And one of the things I was pondering was, is that maybe a reason why methotrexate doesn't look as good in these retrospective studies? So we decided in our trial to study the maximum doses of these medications, the maximum doses that are used for autoimmune conditions. And so we gave a little dose for the first 2 weeks to make sure it was safe and patients were tolerating, but then we really went up to the full dose so that we could give each drug the maximal chance to demonstrate efficacy. Treatment success was our primary outcome, and that was really a composite of having inflammation control in all parts of the eye, being able to taper steroids down to 7.5 milligrams of oral prednisone, and not having any major safety or intolerability events. So here's our primary outcome results at 6 months, and you can see in the blue line there, you can see that that's showing what the treatment success is. And if you look in the methotrexate group, 67% of patients receiving methotrexate achieved treatment success versus 57% in mycophenolate mofetil. So 10% favoring methotrexate. This was not statistically significant. And when you look at 12-month outcomes, we did continue with the same drug if patients had treatment success at 6, and about 80% of patients were able to get off of steroids and maintain control at 12 months. We also found that if the patient is not having control at 6 months and switch after that, we did find that patients who failed mycophenolate and then switched to methotrexate did a lot better in terms of control than the other way around. So all of these are kind of very practical questions that we face when thinking about using these meds. Trials provide the opportunity to answer many secondary questions of clinical importance for our patients, from quality of life measures to looking at clinical and laboratory predictors of treatment success or failure. I've had the privilege of working with many students, residents, fellows, and faculty on numerous projects and collaborations coming out from the FAST trial, and that's helped to extend the impact of the trial. One such collaboration is with Dr. Edmund Choi from UCLA, who is using OCT images from the FAST trial to correlate imaging findings to clinical measures. For instance, he's looking at a measure of vitreous intensity as measured by OCT images from the FAST trial and finding that that correlates with vitreous haze that we grade on exam as ophthalmologists, and that's a qualitative measurement. He's also doing work looking at AI-based segmentation of fluid on OCT images and finding that that's actually providing additional prognostic signal for visual acuity outcomes and change compared to traditional measures like just looking at macular thickness. I'm excited by this kind of work because we do need objective measures of outcomes and of clinical improvement in our field. Right now, most of it is just qualitative. So in summary for the FAST trial, we found that the more expensive drug is not superior and that both drugs had a good safety profile. And so I think it's reasonable to consider methotrexate, which is widely available around the world, as a reasonable first-line steroid-sparing treatment. And also I think the trial shows that the approach of starting with high dose and lowering if there's issues or intolerability is a viable approach that can maximize efficacy. Definitely want to think this kind of work is not possible without the dedication of all of our investigators across the globe. And we had many, many meetings to really get to know everyone, and it truly became a collaborative effort, including, you can see on the two pictures on the right, I just want to point out again that the program official is very, very involved in this kind of work. And my program official, Don Everett, he's the tall man, so you can see his head in the back behind, in the two right-hand photos in the very, very back. Just his head is visible there. But he really got to know all the investigators, coordinators, and his support and guidance were really instrumental to help us to succeed. So moving on, in clinic, I see patients across the age span, and I have a special place in my heart for children who have uveitis. This is juvenile idiopathic arthritis-associated uveitis, also known as JIA-associated uveitis. We are fortunately a lot better nowadays at treating this condition, which used to result in a lot of vision loss and blindness. We have biologic drugs now, like adalimumab, that target tumor necrosis factor alpha, that are highly effective for helping us control inflammation. However, these biologics are expensive, and even though we have biosimilars now to adalimumab, the drugs are still very expensive, including the biosimilars. My colleague, Professor Ramanan, who's a pediatric rheumatologist at the University of Bristol in the UK, led the Sycamore trial across the National Health Service, showing that adalimumab is a very effective treatment when there is insufficient control with methotrexate for JIA uveitis. But now we have lots of patients on adalimumab, and this is a question that comes up. This is from one of my patients, and everywhere people are asking this question. Okay, I'm doing well on adalimumab now. Can I stop it? Well, why do people want to stop treatment? Well, it's expensive, I showed you that. It is an injectable drug, and that's a burden for patients and families. There's a risk of adverse events, including infection, and there's just an inherent desire to be off of medication if you're doing well. So what happens when you stop treatment? Well, there was very limited data on discontinuation and no clinical trial data. My colleague Anat Galord shared this Facebook blog from a JIA parent group, and you can see that it really highlights a lot of the concerns that patients and families have with trying to stop therapy. You might think, why can't we just stop or try? Well, adalimumab and many other biologics are monoclonal antibodies, and so we can develop antibodies against the drug, and sometimes that leads to very low drug levels and loss of efficacy. And there's a concern that stopping drug or taking a drug holiday can lead to increased risk of forming these anti-drug antibodies. And then if you were to fail stopping and then have to restart, you may not be able to regain control of the inflammation. So that's a really big concern, and I think it's demonstrated here. What about guidelines? Well, the American College of Rheumatology guideline officially is that after 2 years of control in JIA uveitis, you can try to taper or stop therapy. But they acknowledge that there really was insufficient evidence, or there wasn't a lot of strong evidence to support this guideline. So, hence, here we got to this question. We wanted to answer it, and this is where we led to the ADJUST trial, again funded by the NEI. And the purpose of this was to just compare time to recurrence of ocular and joint inflammation in patients who are doing well on adalimumab, had controlled inflammation, but comparing stopping versus continuing. And secondarily, because I mentioned that there's concern if you try to stop and then that fails, are you able to regain control? We wanted to look at that. So again, a practical question that we were hoping would provide data for both doctors and for patients and families to manage this condition. So ADJUST was a 1-to-1 randomized double-masked trial. So patients were randomized to receive equally, these medications looked equally. They were completely masked, so they either received active adalimumab injections or placebo injections, and that was donated by the company. And our sample size was 118 patients, our target sample size. Our primary outcome was a recurrence of inflammation either in the eye or joint inflammation, and we had very specific criteria for that, and we followed patients for 12 months. So another notification. I feel like every time we start a trial, something happens. But here, this is from February. So this wasn't really anything, but this was February of 2020. And this was a email, just a big notice that came to everybody at UCSF saying, there's this thing called the novel coronavirus, but it's not a big deal. The flu is a bigger deal. You don't have to wear masks. That's what this says. But fast forward to 1 month later in March, and basically this says you have to shut down everything. And we are just started. We had one patient enrolled at Children's Hospital of Philadelphia, and everything had to shut down. So again, this didn't just affect me, of course. This was massive for researchers, for everyone around the planet. But thanks to NEI, again, their understanding and working with researchers, I'm sure many of you had this as well, we were able to eventually resume as sites were able to come on board. And this was a study partnership done with the National Health Service, many sites across the US and Australia. And so you can see that this really was a joint effort by many, many centers who are very dedicated to do this trial in children during the pandemic. We had a planned interim analysis in February of 2024, and at that time, the DSMC said, you don't need to enroll any more patients, you've met your pre-specified stopping criteria, please disseminate your primary results, but you can continue to follow, to complete the follow-up period for the patient. But we did disseminate our primary results here in 2025, and I'll share a bit about what we learned from that. So let's get to the primary question of, okay, if you stop versus you continue, what happens? And so here you see a Kaplan-Meier plot, which shows time to treatment failure, and you see it in the red is the placebo group, so not getting active drug, and then the blue are the patients continuing on active drug. And there's obviously a huge difference. This was very statistically significant. And the rate of recurrence was about 70% in patients who stopped. That was much higher than any of us in the field anticipated. Well, so we had a lot of people who unfortunately had recurrence, but they all restarted therapy. So what happened with them? Well, fortunately, they were able to regain inflammation. It took a few months, but they were able to regain control. I will say that that's not without consequence, though, because when you have a recurrence of inflammation, you have to be back on steroids, and we are sorting through all of that now, but patients can have high eye pressure from that, and there are real consequences. But fortunately, they were able to regain inflammation. We're now looking at a lot of secondary outcomes, and Allie Coyne, who's here, who is a lead research data analyst in my group, is helping a lot with this. We're looking at a lot of different measures that we collected, including drug levels and the development of antibody levels, which is a big question that a lot of people have. And the main things we're finding are that, of course, drug level drops when you stop drug. You can look at on the right side for the patients who experienced failure. But fortunately, when they restart, we're able to get drug levels back up to baseline levels that are not statistically significant from baseline. So that is reassuring. And similar findings for anti-drug antibodies. We did find that anti-drug antibodies went up when drug was stopped, and it was significantly higher when treatment failure happened. But when drug was restarted, again, those went down and ended up back at baseline. So those are all kind of very reassuring findings. So in summary, we found a much higher relapse rate than any of us would have anticipated. The 2 years of remission in the guidelines seems to be really insufficient for trying to stop therapy. So we really advise very close monitoring if you are trying. So because we found a very high recurrence rate, the question is, can we do anything to at least lower the burden for patients and families, since we're not able to really discontinue in most patients? And the thought is that we could have a reduced dosing frequency, so give the drug less often. It's normally given every 2 weeks, but if you give it less often and still be able to maintain control of both the joint and the eye inflammation, that could really reduce cost and reduce patient burden. And so we are very excited to embark on a new trial funded by the NEI called the ADAPT trial. And the goal of this trial will be to study a range of different reduced dose frequencies and to be able to basically generate a curve that's going to provide that information across a range of frequencies and a precision around those estimates. This is really leading us into an era of more personalized medicine, where not only will we have this information, but you could also plug in and include other patient-related factors to be able to really inform patients on what the chances are that they can maintain control with different regimens. We're also aiming to determine the therapeutic drug range of adalimumab for maintaining remission. And so this has been done in some other fields like inflammatory bowel disease, and we're really hoping to be able to do this for JIA uveitis. Big thanks to the NEI for being able to do this trial, all of the patients and the dedicated research group. This wouldn't have been possible without all of these individuals. So I love trials, and I think they're the highest level of evidence we have and that they change practice. But we can't do trials for everything. Trials can be expensive, and sometimes they're just not even ethical, and they may not be always generalizable to a broader population. We live in an era of big data, and we're going to hear about that in the next lecture and how powerful that is. And so I became very interested in exploring how to use big data and all the various data out there to answer questions that maybe couldn't be done in trials. There's a lot of pitfalls with doing observational research, but more and more with the application of advanced methodological techniques like causal inference modeling, you can help to mitigate some of those limitations. So the condition that I've been studying, and my group's been studying using large data, is herpes zoster ophthalmicus. Herpes zoster occurs when there's reactivation of the varicella zoster virus, which is also known as chickenpox, and this results in a painful blistering rash along a dermatome. When the reactivation occurs in the ophthalmic branch of the trigeminal nerve, it's called herpes zoster ophthalmicus, or HZO. This can result in skin lesions, as you see here, these painful blisters, or it can also actually affect structures inside the eye, and that can cause vision loss and blindness. It can affect many different structures in the eye from front to back. This work is supported by an R01 grant from the NEI, and I've had the pleasure of working with our faculty biostatisticians and many trainees who have been instrumental in helping to do this work. So I think that zoster is a very interesting condition to study because there's been the introduction of different vaccines that can affect the epidemiology of this condition. So starting in the mid-1990s, the chickenpox vaccine came out in the United States, and there's almost universal coverage in the US of children for this vaccine. Most kids now get the chickenpox vaccine during childhood. This means there's very little exposure to wild-type infection in the general population. Most people are not around people who have active chickenpox vaccine. We also have zoster vaccines that have been introduced. The initial one in 2006, and then the more current one, which is the only one available in the US now, which is the recombinant zoster vaccine known as Shingrix, and that came out at the very end of 2017. This is a highly effective vaccine, more than 95% effective efficacy in trials. It takes 2 shots, and the current recommendation is that everyone ages 50 and above should get it if you're immunocompetent, and if you're immunocompromised, ages 18 and above. My group has been very interested in studying the epidemiology across age groups because we do see that these vaccinations have the potential to change who's at risk. So this was some of the early studies we did looking at the period from 1994 to 2018. And basically what we found is that the older groups, and I should say that this 2018 means it's before the recombinant zoster vaccine period, but it does capture some of the years of the zoster vaccine live, which was the first vaccine that came out. So you can see that for many years, basically the incidence of herpes zoster and zoster ophthalmicus were going up across all the different age groups, except for the very youngest kids because they were being vaccinated with chickenpox vaccine. But otherwise it was going up. But then in the era where you had the first zoster vaccine, you start seeing a decrease in the oldest groups, but actually an increase in the groups that are not age eligible for vaccination, the so-called middle-age groups. We're continuing to look at this question now and really bringing it to the current time, which is the era of having the recombinant zoster vaccine, and finding similar findings here where we're seeing that there's definitely decreases in the older groups that are vaccine eligible, so the above 50 group, and decreases in the very young group, the 30 and below, who are all vaccinated, generally vaccinated for varicella zoster chickenpox. But we are seeing continued increases in the middle group. And so this is something that I think needs to be followed because there's a lot of changes going on in the epidemiology. We've also found that this vaccine, the recombinant zoster vaccine, is highly effective in preventing eye involvement from zoster. And as ophthalmologists, we can make a big difference in preventing this condition by raising awareness of the vaccine. I should mention that we use insurance claims big data sources for these studies. The previous study had a cohort of about 60 million patients, and this one has about a little bit more than 5 million. So this is very large data, and we apply a lot of different causal inference modelings to take into account the fact that people who get vaccinated are different than people who don't. Another question of particular interest to ophthalmologists is whether there's a risk of increased inflammation in the eye following zoster vaccine or following zoster vaccination in patients who've already had herpes zoster ophthalmicus. So patients who've already had HZO and then get the zoster vaccine, what happens to them? Well, the official recommendation from CDC is that everyone should get the zoster vaccine even if you've already had zoster. But there's really no data for this group of patients because the original trials that led to approval of the vaccine excluded patients who had a previous history of zoster or zoster ophthalmicus. And so this is one of the questions that has come up in our field, and people who take care of these patients, my colleagues and I, do see patients who have increased inflammation after vaccination, but we have to be very careful not to just make conclusions because of that. And so we've started to study this question, and our initial study on this did find a signal of some increased inflammation following vaccination in patients who already had a history of HZO. Caveats are that I think we need to be careful with this kind of stuff because it's not causal. When you have observational research, these are associations. But we are now looking into factors to try to identify which patients are at highest risk of having this immune activation following vaccination. There's also been a lot of really amazing work coming out and very interesting and I'd say intriguing work coming out on so-called off-target benefits of vaccination, including zoster vaccination, and specifically dementia. Dementia has become a buzzword and gotten a lot of hype this year. So, and it's particularly relevant to herpes zoster and zoster vaccination because we know that herpes zoster does induce neuroinflammation and vascular injury. We know that there's a higher risk of stroke and myocardial infarction in the 1 year following a zoster infection. So there is biological plausibility. We did one of the first studies published on the recombinant zoster vaccine and the risk of dementia using large data. And this was published last year, 2025, in over 4.5 million patients. And we found that getting vaccinated, that's the top, the RZV is the recombinant zoster virus, that if you're fully vaccinated, you have a 32% lower risk of developing dementia over time, adjusting for many other factors. And so, and getting a zoster infection does increase your risk. So this points to a potential additional benefit of getting vaccination. So we're learning a lot about this condition and about the role of vaccination using real-world data from big data sources. And there's a lot more that we want to do, and I'm very excited about this work. And I was continuing on the work, and in the midst of it, about a year ago, we were just full force doing this work when I got this email. I was in clinic. It was a Tuesday morning, and this email popped up on my phone. And it's from a Washington Post science reporter saying that they were somehow told or heard, I have no idea what their sources were, but basically that my grant was terminated, that my R01 grant was terminated. Sure enough, UCSF had gotten an email, but I hadn't even received it yet from UCSF because this was the first termination and they hadn't sent it to me, that my grant was terminated. And I highlighted the specific reason why in pink there, but basically my grant was targeted for conducting vaccine hesitancy research, and that was not in accordance with agency priorities to do vaccine hesitancy research. So I think I know my research, and to my knowledge, I was not doing vaccine hesitancy research. But I think we figured out where that might have come from. And this is, we all know that you can search up research grants and abstracts on NIH Reporter. And so if you look at my R01 grant abstract on NIH Reporter, and this is publicly available, you can see that I do have the words vaccine and hesitancy in this abstract. But the context is that before we got the grant, we had done a survey of American Uveitis Society and Cornea Society asking specialists if they had any concerns or how comfortable they were giving the recombinant zoster vaccine to patients who already had inflammation in the eye. And there was actually a high rate of uncertainty and hesitation is what we found. And so we basically said that because there's hesitation among these ophthalmologists, because there's no data on this, and that's why we want to study it. So because I think I had these words, my grant was targeted. And so, I never went to the press, UCSF did not, but somehow this occurrence of this grant termination got a lot of media coverage, which is very interesting because I usually fly under the radar with the kind of work that I do. I'm not really engaged in that way, but the Washington Post wrote a very in-depth article about it, and so did many, many other media outlets, including in other countries. It was sort of overwhelming. I will say that during this time, I got a lot of support from our community, which was really amazing. I did get some not so supportive messages as well, but overwhelming support. And my program official, Don Everett, checked in with me almost weekly, and it was psychologically difficult for me, but he encouraged me to submit an appeal and really got me through this difficult period. I did submit an appeal to the government and explained what we were doing and that we would publish pros and cons. It's just science, there was no other agenda. And I didn't hear anything for 6 months, but we got it back and we're trying to rebuild the group now. So I'm very grateful to NEI and to Dawn for helping me to navigate what was a difficult time for me and my group. So what have I learned? This is from a beer campaign in the 1980s, and it's just, things are gonna happen in research. There's gonna be obstacles, but just keep on going. Don't dwell and be bitter. Just be better and keep on working at it. We're really lucky we get to do what we do, and I'm really grateful for it. I continue to learn from my patients and my students. They ask the questions that stimulate our research. I am a big believer in collaborative research, including multidisciplinary collaborations and also international clinical trials. I think that increases the diversity in our patient population, and I hope we'll be able to continue those. And then just be persistent, I would say. Enjoy what you're doing and be persistent, and you'll find a way forward. I'm very grateful to everyone that's made the research possible, all of the patients, students, colleagues, my faculty colleagues, my research group, my international collaborators, and NEI, because they funded all of my research I've done for more than 20 years, and all of these other organizations that advocate for vision research for all of us. We're very, very lucky to have all of these groups working tirelessly so that we can do this work. So thank you very much. Thank you.